Welcome to our video on urgency, mixed, and overflow urinary incontinence. Let's get started. Here's an overview of the topics that we'll cover, and we're going to start with urgency incontinence. Now, urgency incontinence is defined as a strong urge to void that is unrelated to an activity or anatomical position. So let's use an image to depict this further. Here we see an artist's rendering of urgency incontinence. On the left, we see an illustration of a bladder that is full of urine. The pink smooth muscle layer is meant to illustrate the detrusor muscle, and the image on the right is meant to depict a bladder affected by urgency incontinence. So in these patients, the detrusor muscle will contract prematurely and involuntarily. In other words, the patient didn't want this to happen, and that causes urine to be suddenly released. And as you can imagine, this is involuntary, so there's very little warning for the patient. Now, because of this excessive contraction pattern of the detrusor muscle, this is sometimes termed overactive bladder. In many cases, urgency incontinence is idiopathic, meaning we don't know what causes it. And patients that are affected typically are over age 40. And patients with neurological diseases, such as multiple sclerosis, can develop this. And it occurs in MS patients because of the sclerotic plaques that can block the upper motor neurons from properly inhibiting detrusor muscle contractions and inhibiting subsequent urination. So just think of those upper motor neurons being affected by MS. Now, anything that inflames the bladder, such as a UTI, can also cause this, which is why when your patient comes in and they're worried they have a UTI, or you're thinking they have a UTI on exam, then you can ask them, are you feeling urgency, like the urge to urinate? Because sometimes they come together. Now, finally, previous pelvic surgery can be a risk factor. So how do they present to you? Well, these are the patients that are unable to make it to the bathroom in time. So they're going to complain about that when you're talking to them. Like, I just can't make it on time. I just feel like I've got to get there and I just can't do it. And oftentimes they experience nighttime voids or get woken up by that urgency to urinate. Interestingly, something as simple as the sight of a bathroom or the sound of running water can actually trigger urination in these patients. And that's unfortunate because, again, it's involuntary. They don't have control over it. And really, when it comes to diagnosis, it's the clinical history that's actually going to help you. And as with most situations in which somebody has incontinence of any kind, you're going to get a urinalysis. And in the case of urgency incontinence, that will be normal. And post-void residual volume will also be normal. So this is when the patient is asked to void their urine and see how much fluid is still in the bladder. And as long as it's less than 150 milliliters in a female, then you're going to consider it as normal. And the initial treatment for these patients is with pelvic floor exercises, just like with stress incontinence, and you're actually going to give bladder training as well. Now, in bladder training, the patient is required to urinate on a fixed schedule, and the designated time interval will actually be progressively advanced each time the patient is successful until they're actually voiding every 3 to 4 hours. And sometimes that works, and sometimes the pelvic floor exercise works. But in the event that that doesn't work, then you're going to want to employ pharmacologic agents. For example, an anticholinergic medication such as oxybutynin. And these work because they block anticholinergic receptors in the bladder to then increase the bladder's filling capacity. So they kind of expand more before the patient feels this urge to go void. A newer drug that's given in patients with contraindications to anticholinergic drugs, or if the treatment fails with something like oxybutynin, you can actually use mirabegron. This is actually a beta agonist, specifically a beta 3 agonist, and it also helps the bladder to relax and fill more. And both of these medications, anticholinergics or mirabegron, can have the potential to increase urinary retention, which is actually totally logical when you think about it. You're trying to help the patient's bladder retain more before needing to void. But if you overshoot that, then you can create a new problem and they actually have clinical urinary retention. And if you need help memorizing some of the mechanisms of action and the different drugs like those we've listed here, then you can see our image mnemonic video on incontinence medications. Now, finally, botulinum toxin or even sacral neuromodulation can be offered to these patients if conservative therapy fails. So they've tried the pelvic floor exercises, you've tried to train them in their bladder, and you've even tried medications. If none of that works, botulinum toxin or sacral neuromodulation. Now, how do these work? Well, the botulinum toxin is a neurotoxin that you can actually inject into the detrusor muscle and help suppress its activity. You're trying to help it not be so active. Now, sacral neuromodulation is a device used to alter the neural firings within the bladder. So as a brief review, you're first going to try helping them exercise their pelvic floor, help them exercise their bladder through scheduled training. Then you can advance to drugs. Then you could advance to just decreasing the activity of the bladder through a toxin or through sacral neuromodulation. Okay, now let's test your understanding with this question. A 72-year-old female patient with a history of atrioventricular heart block, COPD, and angle closure glaucoma is seeking pharmacologic treatment for her urgency incontinence. Which aspect of her history precludes her from the first-line medication used to treat this condition? Okay, well, the first step in correctly answering this question is recognizing that anticholinergic medications are the first-line medication used to treat urgency incontinence. Remember, the example we gave was oxybutynin. But now you need to think of the key side effects of those drugs. And you may recall from your step 1 studies that common side effects of anticholinergic medications include patients becoming red as a beet, dry as a bone, mad as a hatter, full as a flask, and blind as a bat. And the phrase blind as a bat refers to the pupillary dilation that these drugs can cause, which is the primary concern here since this patient has a history of angle closure glaucoma. So you don't want to give her this drug because you could precipitate another attack. And you may recall during your step 1 preparation vignettes that would describe a patient that gets eye redness, sharp pain, and blurry vision while they're sitting in a dimly lit movie theater. Well, that occurs because the pupil becomes rapidly dilated in the dark as it tries to allow more light into the eye. And that can actually prevent aqueous humor from properly exiting the eye. The idea is that when the fluid is trapped, that intraocular pressure actually rapidly rises and causes acute angle closure glaucoma. And that same thing is true if you give a medication that can rapidly dilate the eye. So you don't want to give an anticholinergic medication like oxybutynin to this patient with a history of acute angle closure glaucoma. So in answer to the question, it's that angle closure glaucoma history that would prevent you from giving oxybutynin or another anticholinergic. We'll now briefly define mixed incontinence. Mixed incontinence is the term used for patients that have symptoms of both urgency incontinence and stress incontinence. As an example, this could be a patient that urinates with sneezing, but also wakes up at night to rush to the bathroom. And the first step in management would be to have the patient complete a voiding diary. In this, they should also track all of the fluid that goes in, everything they're drinking, and all the fluid that comes out, and then any episodes of leaking. And this is so helpful because it can help delineate the primary type of incontinence. And whatever's more of the problem, the urgency or the stress incontinence, that's what you're going to treat first. In other words, think of urgency incontinence and the stepwise fashion in which you would advance your treatments. And then think of stress incontinence from our stress incontinence video and how you would advance your treatment there. And you're going to basically follow the treatment regimen associated with the more severe issue. Is it the fact that they just feel urgency and need to get to the bathroom really quick? Or is it that they leak every time they cough? So basically it's super intuitive. Just figure out which is the big problem and then treat that first, and then kind of adapt your strategy to the specific needs of the patient after that. Now onto overflow incontinence. Overflow incontinence is defined as the excessive accumulation of urine within the bladder. And this can be due to one of two things, either malfunctioning nerves or even physical obstruction. So let's draw this out. Now, as you recall, there's a nerve that innervates the detrusor muscle to help urine be released. And if this communication isn't occurring properly, then urine won't be released. Additionally, if there's any sort of blockage within the urethra, then urine won't leave. It can't leave. Now let's talk risk factors. There are many reasons that a patient can have malfunctioning nerves, so let's start with that. Those causes include diabetes, alcoholism, epidural anesthesia, spinal cord damage from something like Cauda equina syndrome, or even multiple sclerosis. Now, epidural anesthesia is commonly given to pregnant patients, and it can actually blunt the signals for urination that are normally sent by the spinal cord. And because part of that mechanism involves a decrease in the tone of the detrusor muscle, then you actually might hear the term bladder atony, atonic bladder. It's just not contracting. You've anesthetized it, you've paralyzed it, so to speak. Now, multiple sclerosis is important to pay particular attention to because we actually talked about it as a cause of urgency incontinence as well. So this is kind of interesting because urgency incontinence is overactivity of the bladder, while overflow incontinence is basically decreased activity, which means that MS has the potential to result in either overactive or an underactive bladder, depending on the part of the CNS that is affected. Now, the causes of physical obstruction that can cause are quite varied. They include pelvic organ prolapse, fibroids, and urethral obstruction after a surgery. A common surgery that would cause this could be the sling procedure performed for stress incontinence. And in that lecture on stress incontinence, specifically referring to management, I talked about how you want to start with something simple like Kegel exercises before moving to the gold standard treatment, the mid-sling surgery. And when you think about the potential side effect of causing overflow incontinence by doing that surgery, then it makes sense that you don't want to jump to surgery immediately because it comes with risks. You might actually create overflow incontinence. Now, how does a patient with overflow incontinence present? Well, it's important to think about how the patient is experiencing this. What are their symptoms? Well, if they have a full bladder, then they'll experience lower abdominal pressure and even a suprapubic fullness. So that's very intuitive. You got a big bladder, you're going to feel like you have a big bladder, and you're going to have more pressure. Now, there may also be dribbling of urine or even hesitancy and a weak stream of urine. And this is why we actually call this incontinence, because after all, they're not urinating enough or when they need to, because the bladder is not very active, so to speak. But when it gets so full, some just might squeeze out. That's what we call dribbling. So that's considered incontinence. But their bladder still doesn't empty. It just dribbles out inconveniently. Now, in these patients, the post-void residual volume is greater than 150 milliliters, and that's super intuitive. All the different types of incontinence we've discussed up to this point, like functional incontinence or stress incontinence, urgency incontinence, those all have a normal post-void residual volume, so less than 150. It's very logical that they'll have too much, greater than 150. They simply can't urinate everything that's in their bladder. Urodynamic testing can also be performed in complicated cases when you just don't have enough information, even with the post-void residual volume. And those are typically performed by a specialist. Okay, so your patient has overflow incontinence. What do you do for them? Well, you want to help relieve the bladder of excessive urine. So you can actually employ urethral catheterization. You can also have the patient time their voidings. So in that situation, the patient's actually asked to attempt to void at regular intervals. So it's kind of similar to that urgency incontinence. But ultimately, you need to figure out why the patient has overflow incontinence, and then you treat that pathology, because that is not normal. Now, here's a review table that summarizes much of the information covered in this lecture and the previous lectures on urinary incontinence. So we're just adding to this table over time. We've talked about the top 3 rows in one video, referring to transient incontinence. Then we talked about stress incontinence. And in this lecture, we talked about urgency incontinence and overflow incontinence. And referring back to this is really helpful before you take a test or when you just need a reminder on how to keep these ideas separate in your head. Now let's wrap up with a question. A 52-year-old female patient presents to the doctor for the first time in 10 years after initially being seen for polyuria and polydipsia. She reports a tingling sensation in her feet, significant difficulty urinating, and occasional dribbling of urine. Her post-void residual volume is 400 milliliters. What is the most likely underlying diagnosis? Now, given the frequency of the underlying disease, this can be actually pretty straightforward. So the correct answer is diabetes. And the patient has had this for a while and they were just lost to follow-up. That polyuria and polydipsia really are classic for the initial presentation for a diabetic patient. And now, fast forwarding 10 years into the future without any management of her diabetes, she has some complications of that. So she's got tingling sensation in her feet, significant difficulty urinating, and even dribbling of urine. And you can attribute these findings to diabetes. For example, the tingling sensation in her feet is likely from peripheral neuropathy. And those urinary issues can also occur as a result of diabetes. And nerve damage can also result in those urinary problems, like dribbling that comes from overflow incontinence. So in summary, this patient has overflow incontinence as a result of nerve damage from long-standing diabetes. And that concludes this section.